Quick introduction for you here. For those who do not know him, Dr. Mahn is a 1985 graduate of Marquette University, their School of Dentistry, and a 2004 graduate of Capital University, where he earned his doctorate in Integrative Medicine. He's been an early adopter for many laser CAD/CAM and imaging technologies. In 2016, he got smart and sold his practice in Wisconsin and moved his family down here to the Phoenix Valley, all right, where he started his own practice called Natural Dental Partners. Is that correct? Okay. So he's going to talk to us a little bit more about airway. Get some more airway stuff today here. So please welcome to the stage Dr. Ingo Mahn.
Thank you. Appreciate it. All right. Well, thank you very much. Nice round of applause. It's kind of not used to that. So, it's great to be with you. Talk about airway. Actually, I want to thank Michael Gelb for giving my lecture this morning. So what we're going to do is we're just going to go out to the pool, and I'm just going to buy everybody margaritas, okay? No, it was great hearing what Dr. Gelb had to say, because it really kind of makes you aware of the scope of this problem. And what I want to do is kind of share with you a little bit of my journey of how I got here, because it's definitely taken a lot of twists and turns. And first of all, I actually want to welcome you guys to Arizona. I did get smart. This is about 15 minutes from my office, and in Wisconsin, if you have a little fishing boat, you get to use it about 3 months out of the year. The rest of the time you're ice fishing, so it's nice to live somewhere where you can actually use your boat for more than a couple months out of the year. So yeah, my journey's has had a lot of challenges, and actually I do want to thank my 3 associate doctors, because when I first started doing this, I didn't realize how much work it takes to implement an airway program. And I think that when you're really engaged in doing all your day-to-day dentistry, it's really hard to do that when you're really focused on that. So having some associate doctors that I can really trust and take over that part of the practice has made it so much easier for me to focus and learn about the airway stuff. So, the biggest challenges are really that it kind of takes you out of your comfort zone. As a lifelong restorative dentist, I love predictability. I can sit down with my CEREC machine, and you put a quadrant of bombed out teeth with old amalgams in it. I know exactly what's going to happen over the next 2 hours, and I can say with certainty to the patient, hey, if you pay me this amount of money, we do this procedure, you're going to walk out of here with this beautiful quadrant of restorations that are going to last you a long time. Well, that's not the case when you first get into airway. There's just so much unpredictability with it. You're talking about sometimes programs that last months and even years for people to really see full results. So when you first get into it, to tell patients, hey, we're going to charge you $8,000 to $9,000 for an airway program, you want to be able to say comfortably, this is going to work and do what I'm telling you it's going to do. And of course, the training can be very lengthy. You probably know about some of the training programs, how expensive they can be. And even studying with some of the better known institutes, I spent a lot of time in taking a lot of courses, and it basically just ended up, you were titrating a tap appliance to build a mandibular advancement device. And really that was the problem, is that a lot of the treatments, I learned a lot of things. I learned a lot of things about airway. I learned a lot of things about diagnosing, but the treatment ended up not being really in line with what I wanted to do as a holistic dentist. It's almost like if they send us back to school, back to dental school right now, and they were sitting up there, teaching you to do amalgams and endo and PFMs. It's like, okay, I understand the problem. I understand it needs to be treated, but this is not how I want to be moving forward with the treatment. So, a lot of times recommendations were full mouth reconstruction, orthodontic surgery, and of course, really the treatment that is by far the most prevalent right now, which is a mandibular advancement device. So I think, mandibular advancement devices do have their place, and they do work. And I think most of you maybe in here do know how we basically take the records for that. We're essentially just having the patient say, hey, how far can you protrude your jaw? And then we just basically make an appliance to kind of go at 60, 70%, kind of pick a number and make an appliance that holds them in place like that. So, you know, when you look at an airway, especially something like this, that, I gotta find the pointer on here. Oh, is this the pointer? Oh, here we go. Oh, it's red today. You know, we get some of these real, I call them fire hose type airways that tend to collapse more easily. When the patient lays down at night, what's gravity going to do? Gravity is just going to pull the jaw and the tongue back, and so essentially the mandibular advancement device is just designed to hold the jaw in place and keep it from falling back. So they can be effective. They have a place in my practice, but ultimately they don't fix the problem. And that's really what I wanted to find as I was going through my airway journey. I was trying to find something that actually does fix the problem. And you know, the reason it didn't fix the problem is because the mandible's not the problem. It's an underdeveloped maxilla. And you know, like Dr. Galb said this morning, it's like almost all of our maxillas are underdeveloped. You quoted something like 95%, and that's what we're seeing with all of the imaging, is that we're creating a whole society of people with underdeveloped jaws. And I know you haven't seen this video before. No, that's exactly what's happening. When you look at that profile, that's exactly the profile of today's kids. And you can just, one of the curses of learning airway is when you walk around, you're just kind of going, oh, there's an airway patient, there's an airway patient. It's like, it drives my wife crazy because we're at dinner. I'm like, look at that patient, they have an airway problem. But you know, that's what's happening. Our faces are shrinking. And of course, you know, here I'm preaching to the choir about Weston A. Price. When I read all his stuff, I know that he focused a lot on nutrition, but you know, he talked about all of the issues. There's a whole generation of children that have grown up that were told, where the moms were told by the pediatrician, hey, you don't need to breastfeed, bottle feeding's fine. And not understanding that the process of breastfeeding is what really starts the whole development of the structures of the head and neck and ultimately the airway. The soft diet, if you look at what we eat now compared to a prehistoric man, their diet was literally the consistency of beef jerky. And we get patients here, it's kind of, you know, we're closer to the Mexican border, and it's kind of funny. Sometimes I'll get a patient that, you know, that speaks Mexican, and I'll look at their jaw and I go, where did you grow up? And they'll tell me they grew up in Mexico. I go, I can tell from their airway that they grew up on a different diet than the next patient that grew up in South Phoenix. And you can literally almost tell where these patients grew up based on the development of their jaws. You know, what we're doing with microwaving food, and of course, the problem with allergenic foods and modified foods is that they can cause a lot of congestion for kids and lead to some more of that very detrimental mouth breathing. So when we're trying to get people to breathe through their noses, one of the things we look at is with the cone beam is how open are the nasal structures. And this is another video that you saw earlier, and you can see that when you measure from gonial angle to gonial angle, this is that video from Nestor's lecture, and even that last jaw is, I think, almost 300 years old, but over time, with the way we're breathing and eating, our faces have just gotten longer and narrower, and there's just simply not enough room for the tongue. So the tongue has nowhere to go but back into the airway. And so ultimately, when that happens and your profile changes, you know, we do pay a health price for that. We get the crowded teeth, the deficient nasal cavity, the symptomatic joints, and then of course the constricted airway. And I haven't focused quite as much on the joints, but we're finding a lot of people that are going through the treatment are getting significant improvement with their temporomandibular joints. So a lot of our patients end up suffering from sleep apnea, and I generally really don't even use the term sleep apnea. in my practice, we really like the term sleep disordered breathing, because as dentists, you have to be very careful about using that term. We don't, only a sleep physician can diagnose and treat sleep apnea. So, we always say we're treating oral contributions to an impaired airway. And that kind of keeps us a little bit out of trouble with the legal community, because if you start telling people you have sleep apnea and I'm going to make you this appliance and help you with it, you're going to be in big trouble real fast. So we want to stay away from that. So the big thing about sleep disordered breathing is it's really a spectrum, and we tend to always, in this country at least, wait until we get to that very the obvious sleep apnea patient that's overweight and middle-aged and stops breathing for a couple minutes at a time, and we miss that huge population that's struggling to breathe, and especially the young fit females, the upper airway resistance patients. That's exactly what you're going to see in your health histories, and I agree with Michael about the health histories make a lot more sense now. So when you look at oh yeah, I've got the adrenal problems, I got the thyroid issues, all of a sudden you're going, hey, is that an airway problem? And really almost, I studied with Jeff Rouse for many years, and he even said, he goes, when I'm talking to a patient and I look at their health history, my first thought is always, show me how this is not an airway problem, because after all the years of treating airway, he's found that so many of these conditions are related to sleep disordered breathing. And the thing is, like, when does the medical profession actually start considering and start treating these disorders? It's certainly not when people are just snoring or snoring with no symptoms. It really isn't until we get to the very end, and it's kind of like that proverbial, the one foot on the banana peel and the other one in the grave. It's like that's when the medical profession finally says, hey, you know what, you should get a sleep study done. We think you may have a problem. So there's a huge population of patients that we have in our practice that are suffering from milder forms of this, and they've been to see doctor after doctor, and that's what always kind of caught my attention. I thought, okay, here you've got people with these medical conditions. They've seen 4, 5, 6 doctors, some of which I know are very smart, and none of them seem to be able to get and figure out why it's happening in the first place. So it tells me that the one thing they have in common is they're all missing the root cause of the problem. And the one thing I know none of these doctors are looking at is the airway. So it really is a huge problem in this country. This is a study from the Lancet Journal of Respiratory Medicine, and this was actually done in Switzerland back in 2015. And so this is not sleep apnea, this is sleep disordered breathing, but they found 25% of women and 55% of men suffer from moderate to severe sleep disordered breathing. So you can only imagine what those numbers would be, post-COVID here in the United States. They're probably at this point significantly higher. So, that doesn't even count the mild. These are moderate and severe. So there's a huge population that's suffering from disrupted sleep due to breathing issues. And it's really, the health effects that are kind of the end result of that. So, because what happens is that increased effort to breathe, and I'm talking about even, people say, well, I snore a little or I make some noise. Really, any resistance to proper airflow will immediately increase the level of cortisol. So essentially people are in upregulated sympathetic mode all night long. And we saw that initially when we did home sleep studies, we just used a basic pulse oximeter, and you could see, especially on women, they would just have these small little desaturations, and then you would see the heart rate go up. Desaturation, heart rate would go up. So they never desaturated to the point where it would be considered an apneic or a hypopneic event, but they were compensating by increasing the heart rate and having these little gasps all night long. But they're paying a huge price for not desaturating. They're paying a huge price in increased cortisol and being in a highly inflammatory state all night long. And we know that the root cause of a lot of the diseases that people are dealing with, everything from cancer to diabetes, has an inflammatory component. So the more we can do to decrease that systemic inflammation and keep them from losing all of the restorative sleep, because it's not just about sleep. That's actually one of the big things that it's nice to get some of this diagnostic equipment, because people don't even realize how poorly they're sleeping. And we probably have a little bit more of an advantage now with some of the sleep trackers. People are, they've got the Oura Ring and the Whoop Band and the Fitbit, and I think even the Apple Watch is doing giving people all kinds of data. So people are becoming aware of this, and that's probably one of the reasons why sleep is one of the, I guess, quote unquote hot topics in dentistry, is because I think it's the awareness is probably driven by patients going, hey doc, it's telling me I'm not getting any good sleep. But a lot of patients come in and they say, hey, but when I tell them, hey, I think you've got a sleeping issue, they go, well, you know what, I sleep, I get my 7 hours of sleep. I go, yeah, but what kind of sleep are you getting? We actually now call it junk sleep. It's like the difference between eating. It's like saying, yeah, well, I got my plate of food, and I don't know why I don't feel good and don't feel healthy. It's like, well, what did you eat? So it's really critical, obviously, for people to get into that proper level of restorative sleep. And if you look at a hypnogram, this is kind of the general sleep pattern that people go through during the course of the night. We generally kind of start out by going into the deeper sleep and maybe pop up a little bit into REM sleep, but this part of the night is when a lot of the physical healing takes place. It was interesting, they did a study where they took a number of women and they kept them from getting into deep sleep levels, and within 3 days, they were able to simulate all of the symptoms of fibromyalgia. So you've got a lot of people out there that are doing all kinds of therapies, they're doing all kinds of supplements, and they're not looking at whether or not they're getting good sleep. The second part of the night, that's generally when you spend more time in REM sleep, a little lighter sleep, but that's when you get a lot of the neurotransmitters balancing, memories get stored, so there's a lot more of the brain things are going on in the second part of the night. And there's a lot of correlation with anxiety, depression, phobias to people who don't get into REM sleep. It's really interesting because as soon as we give patients some of the appliances that we're working with right now, they'll come back and some of them are actually freaking out. They're going, oh my God, I'm like having these crazy dreams. I didn't realize I hadn't been dreaming in years. Well, it tells me that they also haven't been in REM sleep. Same thing, another good indicator of whether or not they're getting into deep sleep is when they tell you they're getting up 3 or 4 times a night to urinate. When you're in proper level of sleep, you're producing antidiuretic hormone and you don't produce urine, so technically you shouldn't be, they're thinking, well, I'm waking up because I have to go to the bathroom. It's like, no, you have to go to the bathroom because you're not sleeping properly and you're not getting into those deep levels of sleep. So when people started wearing these appliances, all of a sudden they're like, oh, I don't have to get up to go to the bathroom anymore at night. I'm having these wild, crazy dreams all of a sudden. So some people actually don't like that. But when you look at now what all of the different conditions that have been linked to sleep disordered breathing, like I said, that's why when you look at their health history now, you go, is there a sleep connection? And more often than not, there is, and that's kind of the exciting thing that led me to think that, or made me realize I was on the right track, because now I get to the point where I look at their health history and I go, I know exactly what their airway is going to look like. Or they tell me about their sleeping pattern. I go, here, let me look at their health history. And invariably, it correlates almost 100%. And really, us as dentists, we're really in a prime position to screen for sleep disordered breathing, because really most of the signs manifest themselves, obviously in the head and neck area. So we already have the most amazing technology. I think we could literally do an airway practice without having any piece of technical equipment. You could, you start doing airway and you sit down with someone, you talk to them for 2 minutes, and I go, I know exactly what you have going on. Obviously, as holistic dentists or any medical professionals, we have to dot our I's and cross our T's and make sure we have good documentation. But it's nice to know that you can literally, when you walk into hygiene and you can teach your team to say, hey, look for these patients, because these are people that we can really help. So some of the indications, grinding and clenching. We now know, after 40 years of telling us, oh, it's a bite issue, now they're saying, oh, well, maybe it's not. There's obviously a reason why people are grinding through their night guards. If it's a bite issue and you've got a bite guard in there and the teeth aren't touching, why are you still grinding? So we now know that as the airway collapses, the body will kind of generate this rhythmic muscle activity to try to keep the airway patent. And now now know that anytime that you see clenching and grinding, there's a good chance that you're looking at an airway issue. So that's what we look for. We look for tori, we look for wear facets, broken teeth, and those are all signs. You used to look at like, oh well, there's some areas of wear. It's like you're just grinding and no big deal. And now we're always thinking about how's this affecting their life? What's going on with them health-wise? Even when we see missing teeth, ask what happened. What happened? Oh, I had a cracked tooth and I need a root canal. I had this and that. Well, why? So as holistic dentists, I think we're much better at asking why things happen in the first place. And again, it tells us, do they have a history of clenching and grinding? And that's how they lost the teeth, or even potentially mouth breathing. The crowded teeth and the V-shaped arch. You see that, and the scalloped tongue. Scalloped tongue is 80% diagnostic for obstructive sleep apnea. So 80% of those patients you see will have obstructive sleep apnea. Those are the statistics. So kind of makes you look at a scalloped tongue in a whole different way. And of course, TMJ pain, and we look at things like the Mallampati score. The other thing that we do is we kind of take this impaired mouth assessment. It's just kind of a simple form that takes kind of all the oral symptoms and all the physical symptoms, and it's just kind of a way that we kind of create a score, and we want to make, one of the things we do is we say, hey, what are your three kind of main concerns? What are the things that if you could wave a magic wand, you could make go away health-wise? And we want to find out for them what really is their reason for being there. So whether it's exhaustion or high blood pressure or head and neck pain, we want to know what that is, because really as we're going through treatment, those are the things we keep asking about. We want to make sure, people don't care if their AHI improved a little bit or their cross-section, the minimum cross-section on their cone beam improved a little bit. They want to say, hey, how much did the symptoms that I came in here for initially improve? So that's something we constantly monitor, and we want to know, are we succeeding in moving them to the right direction? So some of the diagnostic tools that we use, we do a home sleep study, home sleep test on all our patients. The main two that we've used are one is called the one on the left is the watch pad. The nice thing about that is they do have actually a disposable device that's only about $100 that you can, especially with some of the patients that you have that are maybe driving a little bit further to your office, you can literally give them this little home sleep study. It costs, our cost is like $100 on that. You stick a little battery in, you set up their app, and they go home and they can do a pretty good sleep study. They also have another one, that the WatchPad 300, that has an extra lead that will also do respiration. The other one that we like a lot is the sleep image ring. And those are nice because they're very simple to use. And it's actually a relatively inexpensive. That device is actually about the same price as an Oura ring. That unit is $300 right there. And it'll do a full-blown FDA cleared sleep study that you can have read by a sleep physician. And I agree that all the sleep studies should be read, because the last thing the reason we do it is not just to get a baseline, but I also want to make sure that I'm not treating anybody who potentially has central apnea or some underlying medical condition, and then something happens and they're going, well, why are you treating them with an oral appliance therapy when you've got something more serious going on? I think the WatchPad maybe gives a little bit more information than the sleep image ring, but again, the sleep image ring is nice because that's literally what it looks like on a patient's finger. I mean, anybody can do that. We tried some other home sleep studies, the Aries watermark, and people had to wear this thing that looked like a baseball hat and put the I don't know if did you ever use those? Yeah, but you've got the can, and they give you great information, but a lot of patients would come back and just exactly. So almost everybody can sleep. Everybody can put that ring on, and I also actually really like the sleep report. It gives you a sleep apnea score, so that it does tell you what percentage of the time the patient desaturated, 3 and 4%, so it gives you an AHI score. But it takes a lot of the data and this is nice when you sit down and talk to patients and actually show them, because the way it's color-coded, they're going to go, hey, what's the red? And then you can talk to them about their sleep quality and the level of fragmentation. The problem with sending this to an ENT or a sleep physician to have it read is this patient literally, the ENT said, you're normal. And they literally just look at the AHI, and she said, well, yeah, I had a sleep study done before, and they told me I was normal, but she goes, I don't feel normal. I wake up a bunch of times at night, I'm tired all day, I'm exhausted. I know I'm not normal. And I said, well, you're not. You have horrible sleep. You're never getting into that proper level of sleep. But that's not how sleep physicians think. They're looking in terms of, the whole sleep industry is so insurance driven. And if you don't reach the certain benchmarks of a certain AHI, they don't even want to treat you because they know the appliance or the therapy isn't going to be covered. Well, we're looking at things completely differently, and we want to address these things before they get to the point where their AHI is at that level. So people understand that. It makes sense to them that they're just not getting the restorative sleep that they should be getting. So some of the diagnostic tools, you've probably, I would imagine most of you here have cone beam technology. I think in a holistic practice, it's critical. Everything from whether you're doing implants or diagnosing failing root canals or the airway stuff. It's really, really critical to have the cone beam technology. I thought I had a big field of view until I saw that 19 by 21 one. But this is the Sirona model. Back in the 90s, I drank the Sirona Kool-Aid, so everything I have in my office is now, it says Sirona on it. And it's like it's like going Apple. You're not going to buy anything Android once you've gone down that path. But it does give us really good diagnostic information. You can't look at this and say, yeah, you have sleep apnea or you don't. It's still a static shot in time. The people are awake, they're standing, and really a lot of the problems with airway are not so much about the size of the airway, but about the collapsibility. And so there's a dentist I talked to who's got a big sleep practice in Dallas, and he sent 400 of these scans along with a sleep study to a statistician. He said, show me what's the correlation between the minimum cross-section of the airway and the AHI. And he said, the statistician came back and said, I could not find a correlation. Now, obviously, like we were talking, you want, bigger is still better. You want to see someone with a big airway. But like I said, sometimes you get an airway that's relatively large, but it's like the fire hose. It's long and narrow, and it just collapses very easily, where sometimes someone has a smaller, more rounded airway, and it seems to just inherently be more stable. So these are all the things that you keep looking at all this information, and the more stuff you have, obviously, the more useful it is. Now, I was fortunate when I did my upgrade, they were giving away either a free sensor, and I said, hey, I'm getting into this airway. Can I get a cephalometric attachment instead? So it's kind of cool. We actually take a cephalometric on every patient as well, and I do have them do a Sassoon tracing, just kind of like the orthodontists do, on all those cephalometric X-rays, and it just gives me some information that I like. I like to see the angulation of the central incisors. I like to look. There's a reference arc, so it tells me kind of the position of the maxilla. It just gives me an idea of where the problem is for that patient. So it's just one more data point that we can look at. And now that we've been seeing some patients for longer periods of time, we'll retake some of those and actually superimpose them and say, hey, are we getting some of the results that we want? We also do optical scans on all the patients. We love, again, we have, this is of course the Omnicam, because it's got to be Sirona. But we actually, recently, I was working with a company, and they had a scanner. It's called Easy2Scan. The thing was $10,000, and my airway assistant absolutely loves it. She actually likes it. She actually likes it better than the CEREC machine, because this thing, the Germans, when they build something, it's like, you can use this thing as a weapon. It's got some heft to it, where that other handpiece is really nice and light, and it's got all of the AI. So when you're scanning, if you get the tongue or your finger in there, it'll remove those artifacts, and she can do a scan by herself in a matter of 2 minutes. And with those digital scans, it used to be, we've all been there when we used to take all the old impressions, send it off to the lab, and when you get that prosthesis back, you're like, man, please let this thing fit. Because it doesn't take a whole lot for an impression to get distorted, or somebody at the lab to not mix stuff up properly. Well, with these digital scans, it's amazing. I mean, these appliances just snap in beautifully, and it's very rare that we even have to do any adjustments at all. So that makes the whole treatment process a lot more fun when you get the appliance back that you just you can pop it in and not have to worry about the fit. This is a newer piece of technology that we just got. It's called a pharyngometer and a rhinometer, and what it does is it actually uses sound wave technology to show airway collapsibility. And so this is my airway assistant, Megan, and she's trying it out on me. So that's the device right here, and you hear it make this clicking sound. It's just using sound waves, and what you do is you just breathe normally, and then you completely exhale, and it'll actually show where the airway's collapsing. It measures down about 20 centimeters. And then you can also do the same thing with the nose. One of the cool things, because we still do some different appliances, like some mandibular advancement devices, is it actually lets you titrate to see the optimal jaw position for an appliance. So the stuff that I learned, for example, at Spirit, there was you use the tap appliance, and you literally would build this tap appliance. You'd kind of pick a spot, send the patient home, and then you'd call them and say, hey, did that feel better or worse? And then you would just keep titrating it. You'd keep advancing and opening the vertical. And that would take literally months to do that till someone said, well, now that felt worse. So then you kind of back off. Well, it's very, you don't know if that actually was just one night or a couple nights, if, what was going on. And so with this device, we actually have these little tabs, and you can see they come, like this is a 10 millimeter, 8 millimeter. So you can say, okay, let's put you in at 8 millimeters end to end and run that pharyngometer and see where you're, and it'll give you that same, just like that cone beam, it'll tell you this was the minimum cross-section, the smallest cross-section of the airway. So you keep increasing the vertical and the protrusive till all of a sudden you notice that it starts getting worse. So you literally can, in a matter of minutes without any ionizing radiation, determine exactly where's the optimal position of this patient's jaw to keep their airway the most stable. Again, it's just one more tool. It's, right now their airway is in such an infancy. I think we call it, what do we call it? Like the wild west of, of dentistry, because it just seems like, we're trying to find all the answers. We want the science, but the fact is, there's not that much data on some of the things that we want to know. We want to see a study like, okay, if I do this, what's going to happen? But those things just don't exist. So hopefully, with more and more dentists doing these kinds of procedures, we're going to start seeing that kind of data coming in. So as far as treatment goes, before we begin, we do compile a lot of diagnostic information. I'll just show you just kind of like a screenshot. This is literally all the stuff that we take photographs, we take pictures in front of the posture grid, we do a lot of intraoral photography, checking tongue position, tongue ties, there's sleep studies. So we literally, for every patient, we want to make sure we have a lot of data that we can use as a baseline and to show that the treatment that we're doing is working and that we're providing them with the proper appliance. Just a couple notes. If we see that it's a real severe case, we'll definitely work with an ENT and a sleep physician. And then the other thing is, you never want to take a patient off a CPAP, because being holistic, they hear about our practice, they hear that you're doing sleep, and they come in and they're like, my husband's on CPAP, and you're like, can he stop using it? Can you do something for him to take it off? And so we always say, even in our consent forms, we're very clear. We say, if you're wearing a CPAP right now, don't stop using it until you're told to do so by your sleep physician. That's just another one of those things that will get you in trouble when you tell a patient, yeah, you can throw your CPAP away. Just use this little magic device. We don't want to do that. So the appliances that ended up kind of making the most sense to me, and after using a whole bunch of different ones that worked in my hands, were the epigenetic appliances. And epigenetics, I think in our group, we're probably way more familiar with that term, but it's essentially just how your genotype is expressed. So we can actually, with these appliances, and this is the appliance that I've been using the most. This is called the HomeoBlock. These are actually orthopedic appliances, but what it's actually doing is it's not. It has a whole different method of action than an orthodontic appliance. So when you tell an orthodontist that what you're doing here, they look at you and you go, well, that's impossible. You can't do that. I go, well, we're not causing expansion at the palate. We're literally signaling the body. So there's three main components to this appliance. You've got the uniblock that you put on the one side. There's a way to determine which side of the face is underdeveloped. There are the T-springs, and then there's the expansion screw. And if you've seen any of the Vivo stuff or some of the other things, a lot of these appliances are very similar in design. But essentially what happens is, by chewing on the one side, and you would think that would be kind of an uncomfortable thing, because I always hated I went through braces, I hated having appliances or retainers or anything in my mouth. I put this thing in, I go, it actually feels oddly soothing. And that's what our patients are telling us. It's like, you would think it'd be very uncomfortable, because as dentists, we're always trying to balance the bite. But when you're chewing, you're not chewing on both sides, you're chewing on one side. So that's what these appliances do. And the part that's on the palate is actually slightly off the palate. So the way the appliance works is it forces you to swallow correctly, and when you press your tongue up on the roof of the mouth, not only does it have to travel further in order to do that. And as Dr. Ted Balfour said, it's like taking your tongue to the gym. So you're strengthening the muscles of the tongue. But then these T-springs are putting light cyclical forces on the teeth. So it's really a process called mechanotransduction that's signaling the body to remodel itself. So we're not just causing, we're not cranking on this expansion screw to create the expansion. The appliance is actually causing the palate and the jaw to remodel. And then about every 2 weeks, the patients, there's a little hole in there, and you can see the little arrow. So they take a little key, they turn it, they give it one turn, and that's about 1/4 millimeter. And about every 2 weeks, they make that turn because it actually, the appliance starts to get loose, and they turn it, and then it fits normal again. So all you're doing with the expansion screw is really keeping up with the changes that the appliance is creating. And it's amazing. You see people after 3-4 months, and that space will be 3-4 millimeters. And the amazing thing is you would think there'd be all kinds of spaces between the teeth, but the way it's remodeling, we haven't seen the spaces between the teeth that you would think you would get from creating 3-4 millimeters of expansion. The monoblock design I just thought I kind of would throw up the history just so you can kind of see like how this all kind of came to be. So the monoblock design was actually around for a long time, since the 1900s. And I was fortunate to study with a number of these practitioners, and Dr. Balfour had a practice in right off of Central Park. He had a lot of performers in his practice, and he was trying to figure out how can I straighten their teeth and fix their bites without, because they didn't want braces. I didn't want to put a bunch of wires and braces on. So he brought this very experienced orthodontist in, and they developed the homeoblock. And that was really what led to the development David Singh's DNA appliance and Dr. Felix Liao's Start Thriving appliance. And then there's also Dr. Scott Simonetti, who took the homeoblock and developed this facial block, which is basically, if you looked at the homeoblock, it just had the one split right down the middle. This one has more of a Y split, and it actually also lets you move it gives a little bit more movement to the maxilla. So I'll use that if I see the central incisors tip slightly back. We use that to just create a little bit more protrusion of those central incisors. So that's basically the summary of that. They tone the muscles of the tongue that support the airway. They do eventually remodel maxilla, and I think they do a really good job of downregulating the autonomic nervous system. Because the thing that really shocked me was what appealed to me about these appliances was that they were going to remodel the jaw and actually change the airway and improve the airway. And we'd give people one of these appliances, and they would come back 2 weeks later and they would say, "Oh my God, I can't believe this thing. I'm sleeping better. I'm snoring less." And they're telling me all these changes. I'm going, "Wait a minute. This is not from bone remodeling." So. But that's kind of the beauty of these appliances. What's given me a lot more confidence in moving forward is that when we give people the appliance 2 weeks later, they say, "Whatever you do, you're not taking this appliance from me. When I sleep with this, I sleep better. I wake up more refreshed, and I'm not snoring at night." So it's from what I've seen, and I don't have anywhere near the experience that Dr. Galp does, but just in the time that I've done these appliances, I've been extremely happy because the patients are having really wonderful results with them. So ultimately, the airway treatment is a team effort. We now have a myofunctional therapist in the office. We work with allergists, so if someone is congested and it's like, we've got to clear that up. We work with chiropractors, craniosacral and PT people. Fortunately, we don't have to work with nutritionists a lot. I think this type of airway therapy is really tailor-made for our holistic practices. It's the patients that are coming to our practices, they want they don't want just a mandibular advancement device. They want something that's going to fix the problem and give them long-term results. And by the way, the other thing, as soon as Healthy Start is getting lots of great plugs here today, and deservedly so, because when you start seeing these adults, you're looking at them going, man, you talk to them, they've been suffering with these problems since childhood. And all of the ADD stuff, I mean, we've made all that worse. We've created these problems. And so to be able to see these kids at age 3, 4, 5 and get them into habit correctors and start, getting them started on the right path, our goal is that they never will need to have this kind of therapy and have the types of health issues down the road. So I went home and I changed that slide. I added an extra, I had 3 books up there, but I added the gas book. I bought it on Amazon, so I'm looking forward to reading it. But Breath is definitely one of those books, and I did the same thing. I have a whole stack of those. I also like Dr. Liao's book. If you really want to get into some heavy-duty stuff, Dr. Singh's book really has a lot of science. I mean, the guy's done some amazing research. But this is the state that we're in at Airway. I've been studying Airway for 5, 6 years, and I read James Nestor's book, and I'm literally blown away by all the things. I'm like, nobody's ever talked to me about the importance and role of CO2 and nitric oxide and the nasal breathing. So he's a very entertaining writer, and it's the kind of book you can give to your patients. They actually love reading it, and when they read that, by the way, he also talks about how these appliances are almost like a holistic facelift. When people start wearing these appliances, I have women come into the office now that say, yeah, I heard that these things improve your cheekbones and get rid of the mucolabial folds. And I said, you can't, yeah, like Dr. Galp was saying, you're literally changing faces. And so the nice thing is when they come in for the aesthetics, I go, well, the side benefit of this will be that you'll also sleep and breathe better. And so for the people that come in for the breathing and the airway stuff, I said, well, the side benefit is that you're also going to look better. So it's a win-win. All right, so yeah, we have a pandemic in this country, and it's definitely sleep disordered breathing. And the good news is that we as dentists have the tools, and once your eyes are open to all of the signs and symptoms of it, you realize that you literally have an airway practice in your practice right now without getting one new patient. And these people, when you talk to them about this, they look at you like, oh my gosh, like you're connecting the dots for them, and they really appreciate someone that they can have a conversation like this with, because they haven't been able to go anywhere else and get that kind of information. So that's it. Thank you very much.